The American College of Radiology.
Focused. Forward.
Together.
First of all, my introduction, my name is Raj Upadhyay. I'm a radiation oncologist at Moffitt Cancer Center. On behalf of the Radiation Oncology Committee of ACR and our chair, Dr. Amini, I want to extend a huge thank you to our incredible attendees as well as our speakers. It's a phenomenal panel who have made this event possible. So let's get started. So we have a truly exciting hour ahead of us. We are diving deep into biology-guided radiation therapy, exploring how merging real-time biological signals with precision delivery is fundamentally changing the landscape of radiation oncology. It's a dynamic, groundbreaking way of radiation delivery, and I think it's one of the directions where the future of cancer care and radiation oncology is really heading. So I want to start with a few housekeeping items. To make the absolute most of this hour, we want this to be as interactive as possible. So our first speaker is going to be Dr. Park, followed by Dr. Schiff and Dr. Watkins. Following this, we're going to have a panel discussion and live real-time Q&A. But please feel free to drop in questions into the Q&A box as it comes through at any point during the presentations. We will try to answer them right away and also discuss the pertinent, important questions towards the end of the webinar. Without further ado, let's get started, and I will go ahead and introduce our first speaker, who is Dr. Henry Park. He's a professor of therapeutic radiology and chief of thoracic radiotherapy program and PET-guided radiation program at Yale School of Medicine. He's a true powerhouse. He's been a pioneer leading Yale's PET-guided radiation program for a while now. He has published over 220 papers and holds degrees from both Yale and Harvard. And he trained at Juilliard as a violinist, so his precision is turned to perfection. Beyond treating patients and securing NIH grants, he's also a formidable trivia opponent, as I learned firsthand when he recently crushed me in a room full of faculty and residents at Radium Society's Jeopardy competition. So please welcome our undisputed Jeopardy champ and our radiation oncology leader, Dr. Park. Please take it away.
Well, thank you very much. It was certainly not just me, and you were a very formidable opponent as well. and I know you'll be all set for a rematch next year. Today I'll be discussing the background and clinical implementation of BGRT before our next two esteemed speakers. So I'll just give you a very brief overview of what this is, and we'll run through a couple cases that are but I'll just look more big picture, and then you'll hear from Dr. Schiff some more detail. Here are my disclosures. So Reflection X1, it's the first edition of the machines here. That's a novel radiation technology that has the capability of using the tumor's own biological PET signal as a fiducial marker to track the radiation beams in real time. So it's also known as BGRT, as you've heard, and is trademarked as Syntix therapy. Right now, it's only approved for lung and bone treatments. You'll hear more from Dr. Watkins about some other possibilities in the future as well. But right now, you can treat with FDA approval both lung and bone targets. They could either be primary, primary lung, primary bone, or metastases from any primary if those are the targets. But either way, it has to be to the lung or to the bone. The dose fractionation must be with SBRT type dose fractionation, so at least 8 gray per fraction in 5 or fewer fractions. It can also, but the machine is versatile. What's helpful about it is that you can treat with IMRT and SBRT as well. Now, some programs have used this just for BGRT, and other programs like ours actually use this primarily for IMRT and SBRT, but also have some BGRT cases on it as well. So what's the basic principle of the basic idea here of why this may be helpful is that you have a tumor volume here, and I'm not certain exactly who the audience is here today in terms of your background, but this is a somewhat simplistic diagram here of a tumor volume or GTV. You have the gross tumor volume. You have some level of motion, and of course this is a bit exaggerated, but you have some kind of motion in some ways to an ITV or that accounts for respiration in the tumor motion. And then you have a PTV on top of that that accounts for setup error. So with normal SBRT here, you expand the GTV to an IGTV that accounts for motion. You add a few millimeters beyond that. With BGRT, you no longer have to account for the physiologic motion in terms of adding margin to it. So you just take the GTV itself, and then you put you end up putting a 5 millimeter margin approximately on top of that to create the PTV BGRT. Then you have a BTZ. I'll define this as the biological tracking zone. So the idea behind the BTZ is where the PET signal is being tracked. So it's something that you don't want to make it too small, because if the PET signal moves beyond it, then the machine won't pick it up. But if you make it too big, then it'll be really slow, and the treatment takes a lot longer to get done. So you want to choose about the right size, which is about, you basically take the PTV of the SBRT, since that includes the motion of the tumor. You put a margin around that, and then you put another small margin around that. Here's another 5 millimeters to create the BTZ that's used for biological tracking in the Syntex case. So what are some potential theoretical benefits? Tracking the PET signal could decrease the size of the radiation field, given that you don't have to account for the physiologic motion anymore. It could increase confidence in fully hitting our target, since if things move in a somewhat unexpected way, that then automatically will track it. And then this also could theoretically decrease the risks of side effects, although that has not been shown clinically yet. So here's a picture of yield ribbon cutting, which was in 2023. We were the 5th machine installed in the world after Stanford, UPMC, UT Southwestern, and City of Hope. We installed, but we started with just the IMRT and SBRT components first. We then installed Syntex therapy in December 2023, soon after the FDA approval for lung and bone tumors. And then we had our ribbon cutting, and then our first Syntex treatment itself was performed in March 2024. So with IMRT and SBRT, they've had several software upgrades over time that, in my mind, make this quite similar in terms of the overall plan quality that you'll see with other machines. With IMRT or SBRT, you can treat all tumor types. Performance is very similar to VMAT, especially, we tend to use this a lot in lung and GI. We sometimes use this in GU cases, some head and neck cases, some CNS cases as well. But lung and GI are typically where we have the most experience right now. There are a few places where we do prefer VMAT over reflection. Sometimes the fall off of the dose superior and inferiorly is not quite as sharp sometimes. So then if there's a budding critical structures or prior radiation field, especially in the sup-inf direction, once in a while we'll choose VMAT over reflection. Other contraindications to reflection, though, are if you have a pacemaker on the same longitudinal plane as the PTV. This is basically a TOMO unit, so we're not, you don't have any avoidance sectors like you can use with VMAT. If you're claustrophobic, it's a bit of a smaller space and a longer tube, mostly, that so patients who have claustrophobia may not do quite as well with it. The treatment times are a little bit longer as well, so if they get antsy or pain on the table, sometimes a little bit more difficult too. But most of our patients are able to qualify if they would otherwise get VMAT, would also do just as well on the reflection. Image quality is also one of the best things about the machine too, in terms of the onboard imaging as well. The CT scan, the cone beam CT scans are very high definition and good resolution. So now with Syntex therapy, what are some of the inclusion criteria for this right now at this moment in time? Again, this is the X1, that is the initial version. They're actively working on moving towards X2, as you'll hear more about from Dr. Schiff. So the PTV right now needs to be about 2 to 5 centimeters. The SUV needs to be at least 1.5 centimeters, but preferably at least 2 centimeters. The SUV for larger targets, at least 6, and for smaller targets, at least 8, preferably. Although there are ways to assess for this, whether it may still work even with lower numbers. Generally, you want to see a homogeneous PET signal throughout the PTV, and then it'll track best that way. If the BTZ should generally be at least 2 centimeters away from another PET avid OAR. So most OARs in the chest and even they're close to most bones are not too close. But you see the left ventricle there. If you were close to there, sometimes that becomes a little bit difficult to track, and for the machine to tell what's tumor and what's normal OAR. But other than that, that's that doesn't happen all that often. And then motion extent, if it's too extreme of a motion extent, then it may have trouble picking it up as well. There's a couple things here. One's called AC and NTS. You'll hear more about these terms being used, but essentially the AC is the minimum FDG activity concentration that's calculated by estimating the net signal concentration from the target. And NTS is normalized, that's based on the target signal, the AC of the target divided by the AC of the background. So basically the signal to noise ratio. So standard workflow of how this works, there's not a whole lot more to it than your standard SBRT case, except there's one additional day that the patient has to come. So you do your CT simulation on one day. Usually a day or two later, you bring them back for something called a PET modeling. So in between the CT sim and the PET modeling, you're contouring your PTV, the GTV, PTV, this BTZ, and then at least one OAR. You also tell nuclear medicine you need to order FDG for the day of the modeling. The day of the modeling, you ask the patient to stay NPO 6 hours beforehand. 1 hour beforehand, you inject the FDG 15 millicuries, which is a little bit higher than you would get for a diagnostic scan. At the console, you get a cone beam CT like you usually do, but then you would get a PET scan acquired on the reflection machine in the radiation oncology department right afterwards. Then the target's confirmed within the BTZ. The symmetry confirms that this passes, has sufficient AC and NTS scores. You update your volumes if you want to. Oftentimes you don't need to, but sometimes it gives you more information that's helpful, especially if the prior diagnostic scan that you're basing things on is a little outdated. You get some really fresh PET scan to use, and then you get treatment planning underway for both BGRT and SBRT, with the idea that you always have a backup SBRT plan ready to go if for whatever reason on the BGRT day itself that you don't have enough signal for whatever reason, or if something happens, then you have the SBRT always ready to go. And then for each fraction, you inject the FDG, you get the cone beam CT, and then you get a PET scan. And then if everything passes, which it almost always does, then you treat. So just a couple cases really broadly. Our first two I'll show you. One was a left lung metastasis from an endometrial adenocarcinoma, 2.8 centimeters, SUV 9.5. Generally pretty peripheral, but not terribly far from some parts of the tracheobronchial tree, and not terribly far from the chest wall either. So we did something called a synthetic PET evaluation, which is something you can do here from the diagnostic PET scan. So even before the patient walks into your office, once you know that you're getting a referral for a patient, then you see this diagnostic PET scan, you could run that PET through the system. All you got to do is to basically contour the lesion itself and one OAR essentially, and then you put a PTV margin around it, just modeling what it would look like, and you would get a general sense of the AC and NTS, so that gives you a sense of, okay, are we borderline here, or do you think we should go ahead and do this PET modeling? So in this case, we went ahead and did the CT sim. We did the PET modeling. Numbers look quite similar and easily passed on both those metrics. We'll go through all the details here, but basically what we did, especially in the beginning, we ran a VMAT plan on a true beam, we ran a reflection SPRT plan, and then we ran a reflection Syntex treatment. So overall, it's overall pretty comparable plans in general, but with the added benefit of better image quality, as well as the tracking that gives us some confidence as well. Also slightly smaller PTV as well, given that there was some motion here. It is actually a relative decrease of about 42% in terms of the volume of the PTV with BGRT compared to both SBRT plans, whether it was VMAT or whether it was with reflection. There's something called a bounded DVH that you'll get when you're evaluating a plan. This gives you a sense of almost like a 95% confidence interval to give you a sense of what's the best case scenario, what's the worst case scenario. And then you get a sense right after each fraction about what was actually delivered. Which is a very nice thing to see, because on other machines, you don't really get a sense for actually what was delivered and what the actual DVH was that was given to the patient. So there is some bounds here, and they'll only treat if this falls within the bounds, at least 95% of the time, and almost always is 100% of the time. And then here is just a example of an image you would get that would show you what you had planned and what you had delivered. So you can see exactly what happened to your patient and what those lines were from both planning and delivery. Second case here is a bone met in the iliac from adrenal cortical carcinoma. So this was 1.9 centimeters with MRI and PET correlates. So you can see it on both of those, but you couldn't really see it on CT. You can maybe make something out of there, but to really delineate it, not really possible. It looked pretty symmetric actually to the other side, so you really would not be able to see this very well. You could, of course, always match to the overall iliac bone, but you couldn't really match to the tumor itself. So we did the same thing, synthetic PET evaluation from the diagnostic PET scan. We passed the PET modeling afterwards, after the CT sim. We did a plan of 30 gray and 3 fractions, taking great care about the bowel as well as the lumbosacral plexus nearby. And then ultimately, here's what you see delivered. One small issue here was that this is just an example of where my overall contours were based on both the PET and the MRI, but the MRI did show some signal that the PET didn't show. I at the time made a decision to cover everything that MRI showed, but then it was no longer really homogeneous PET signal. So it worked, but it wasn't necessarily perfectly ideal. So I think you have a couple choices there, just to trust the PET signal and treat that, or in this case we actually decided to move to SBRT for the other 2 fractions. But you have certain situations like this that make it not as easy to be able to use the PET tracking if it's not fairly symmetric around your PTV. There's the PET signal. And then we did one multi-target treatment. This is our first one. This one was not incredibly necessary that we had to do a multi-target treatment, but the idea here was we had a lung metastasis as well as a kidney metastasis on the other side. So these were very far away from each other, but this was the first proof of concept that you could do, even with 2 isodose plan, actually do a single plan that treated both of these at once. And everything passed there. I'll skip all this for the sake of time. Just wanted to shout out that we were recently awarded from the NIH and R01 to study deep learning of this PET denoising algorithms. This is an area I think that's very promising and interesting going forward, that AI can help us to really make the image quality even better going forward. So we're hoping that with future future editions of this system, that it'll really be able to get very, very high quality PET images that are even better than now. All right, so in summary, for lung and bone tumors, Syntex may be most useful to decrease high-dose exposure. There's some cost of low-dose exposure with conformality and ability to shave off some nearby OERs, but it can also recenter tumors, the treatment for tumors that shift or change in a manner that may not be detectable by a single cone beam CT. It also can deliver SBRT and IMRT with near diagnostic KVCT image quality. And I really believe the future is promising as capabilities improve to treat multiple lesions, heterogeneously hypermetabolic lesions, non-lung and non-bone sites, and also non-FTD tracers. So I think there's a lot of potential here for the future of this. This is really just the very, very beginning, and we've implemented it clinically to a small degree, but I think once all this can get figured out, which hopefully is in the pipeline very, very soon, then we'll really see the potential for this to really transform the way we treat tumors. Thank you very much.
All right. Well, thanks a lot. That was an amazing talk. I have a lot of burning questions already, which I want to hold on till the end, and we must move on to our second presentation on the background. And this was a discussion on the background and clinical implementation. Now we move on to the role of BGRT in clinic today and tomorrow. We must walk before we run. Our second speaker for the day is Dr. Joshua Schiff, who is an assistant professor of radiation oncology at the Keck School of Medicine of University of Southern California. Los Angeles native, Dr. Schiff's work is all about translating state-of-art tech, specifically adaptive and biology-guided radiation, straight to patient care through innovative clinical trials in lung and GI cancers. When he's not developing next-gen trials or emphasizing deep empathy with his patients, you can find him hiking with his dog, cheering for local football teams, or collecting stamps on his passport. I've heard he's traveled and explored everywhere from Japan through Tanzania. Please give a warm welcome to Dr. Schiff. I'll hand it over for the second part of the talk.
Thanks, Raj. Appreciate that. But thank you guys for having me here to talk today. And I'm going to build off of what Dr. Park kind of set the ground for and talk a little bit more about how we operate with BGRT in the clinic right now, and then, a particular focus on what tomorrow might bring. So these are my disclosures. When I first started to wrap my head around BGRT, I did some background research. And of course, this idea of using biologic signal to guide radiation is not new. I mean, we do it in some ways in our clinic already with PET fusions and whatnot, but the actual idea of a biologic target volume is quite old, dating back quite a while. But at the time when this idea was first conceived, they were somewhat limited in terms of their technology. But as Dr. Park kind of laid the ground for, we now are able to actually deliver radiotherapy directed at a biologic signal with BGRT. So this is our reflection or X1 BGRT machine at USC. And when I think about BGRT in the clinic, I think the first thing I think about is how do I just describe this to patients? And so I think the easiest way to understand it is it's effectively kind of like PET-guided SBRT, right? We're using SBRT-like doses, and we're using PET imaging to actually guide the radiotherapy in real time. And so Dr. Park mentioned the term fiducial, but it's effectively turning the tumor's natural biologic signal into fiducial for treatment guidance. And it's a unique advanced motion management paradigm that we actually can know where the dose is going in near real time. So this is kind of a visual representation of what's happening with BGRT. You don't actually see this on the console, but this is what's happening. So on the left images, you can see that the machine is collecting these limited time sample PET images, which it's then feeding into the machine to direct radiotherapy delivery in real time. And as the couch is passing the patient through the machine, it's kind of building upon that dose using the limited time sample images to direct the radiotherapy. So we do have some early clinical data on this treatment. So the probably most prominent would be from a prospective registry called the Premier Registry, which I believe Dr. Park and Dr. Watkins institutions participated in. So the registry itself was on more than just BGRT patients, but there was an analysis presented at ASTRO a couple of years ago on just the BGRT patients, and specifically wanted to highlight the 31 patients in that analysis that were treated with BGRT with follow-up imaging. It was about half and half of bone and lung tumors. As Dr. Park mentioned, the only FDA-approved indications currently are for FDG-avid bone and lung tumors. Dose and fractionations were typical SBRT dose and fractionations. And at 9 months, we saw excellent local control, no high-grade adverse events, which isn't groundbreaking because this is SBRT doses. We know this is effective. We know that this is safe, but still kind of stands the ground as the kind of earliest prospective data we have on this treatment technology. To highlight a case we've treated here in our clinic, I'll just bring up this patient's an 81-year-old male, has a history of non-small cell lung cancer. He has this small 1.5 centimeter primary tumor with an SUV max of 8.8. We ultimately recommended this patient for definitive treatment with BGRT. Dr. Park mentioned one of the benefits of this treatment compared to a standard ITV-based approach is that we treat less lung. So here in this image, the cyan represents the target volume that was treated with BGRT, and the dark blue is what was treated with what would have been treated with SBRT. And you can see that there's a pretty significant reduction here in this case, particularly as it's a low lung tumor that moved quite a bit. Here's a plan comparison of the BGRT case on the left and the SBRT case on the right. This was a pretty straightforward BGRT case. So, the treatment's fairly conformal. You can see the conformality index is fairly equivalent. The big difference that we see here with BGRT is that it's not able to drive the lower dose volume to be as tight around the target as we would expect with SBRT. You can see that as highlighted by the R50, which is a bit higher in the BGRT plan here. With that being said, that plan was more than acceptable. Here's the dose volume histograms of the SBRT and the BGRT plans, and they're basically superimposed upon one another. Next, I'll share a bone case. So this was one of our first cases treated here at USC. 78-year-old male, metastatic urothelial cell carcinoma, had multiple lesions, including this 12th rib lesion that you can see right here. Ultimately ended up treating this patient with 30 gray and 3 fractions with VGRT. So here's the plan. You can see that, as I'd stated before, the prescription dose is fairly conformal with BGRT, but what it does struggle a little bit with is some of the lower dose volume. With that being said, this was also a acceptable plan. Dr. Park had mentioned some of our BGRT metrics we look for, such as activity concentration and normal tissue signal, normal target signal with this met. And then the treatment time for this was 39 minutes, which is very long. We're now much more experienced with planning, and we really don't see treatment times that long anymore with much more complex plans than this one. So, when we're doing BGRT, we get information that we don't get with any other treatment. We get PET scans for a lot of these patients before treatment and after treatment, but there's really no other setting in which we're getting PET information during treatment. And so I do think that this field does, represent a very interesting space for radiomics and, using in-treatment imaging to help guide adaptation, so to speak. And so that's something interesting in the future. So with that case that I just showed you, the activity concentration, which is the activity of the target, actually decreased during treatment. And you can actually see gross changes in the activity as well. And so that's pretty cool. We don't have any data on exactly what to do with that in this point in time, but I do think that could serve as some pretty interesting way to help derive biologic information from this technology to help guide treatment down the road. Dr. Park mentioned the multi-target function, which is very helpful, particularly if you're treating 2 targets that aren't close enough to treat in one plan, but are close enough to each other to have some dose contribution, because it will actually optimize these 2 plans together. It will take into account entrance dose and exit dose, as well as dose contribution from the other plan when optimizing the other plan, so to speak. So it makes it a very handy plan for these types of treatments. Very handy machine for those treatments. So what are the benefits of BGRT today? Well, the primary benefit is that it's a fiducial-free motion management platform. We don't use fiducials for lung and bone tumors necessarily, but hopefully, if and when this gets into treatment of the liver, for example, this can be very helpful. We talked about the multi-target function, and Dr. Park mentioned, but it has an incredible onboard imaging system as far as a CT scanner goes. I painted a rosy picture, but it's not always that easy to deliver BGRT. There are a variety of things that drive whether or not we can actually deliver the treatment. In our clinic, about half of the patients that we model for BGRT actually progress to treatment, which I think is fairly representative of what other people experience in their own clinics. Our most common issue has been proximity to nearby OARs, but tumor activity is a fairly common issue as well. So what are the challenges of BGRT in the clinic today? As Dr. Park mentioned, there are limited indications currently and fairly strict inclusion criteria, which can make finding patients occasionally challenging. It is more time and resource intensive than standard SBRT, and the real-time guidance, which is excellent and very exciting, can be somewhat abrogated by some of the other challenges of the current state of the technology. So we're kind of in the same place that we were many years ago with the idea of using biologic targeting, although we've certainly taken a few steps forward. But the potential is certainly there. There's a ton of different things that can be done with this technology that we can't do with other radiotherapy delivery devices. Adapting to biologic response during treatment. Of course, we're only talking about FDG, but there are plenty of other radio tracers we would love to see implemented with this. And then this has nothing to do with BGRT, but the onboard CT scanner would be an incredible tool for adaptive treatments if and when that software is eligible for that. The future is on its way, though. So at AAPM just this past weekend, the newest version of the software and hardware was announced, and they're on their way to unveiling that at Astro as well. There are published studies on new radio tracers and more on their way. And hopefully this will all lead to treating more patients with this exciting technology and expanded indications. So we've done some work on some of the changes that will happen with the new platform, the new technology. One is just that the plans are much more SBRT-like, which is very exciting. So for example, this is a plan that we didn't end up treating here at USC due to a variety of reasons. And when we replanned this on an in silico software with the new technology and hardware, we found that the plans were delivered much faster and much more conformal, as evidenced here by the R50 and the lung D13.5. Here's a bone case that we modeled here but didn't end up treating. And once again, when we used the in silico software on the same plan, found that the plan time was reduced substantially and the plans were much more conformal. So new radio tracers will also hopefully be implemented as well on this technology. Certainly some work has already been done. So Dr. Watkins and Dr. Amini's group did a study on PSMA, found that about 40% of patients would have actually passed to BGRT using PSMA guidance. That's fairly similar to what we find in terms of the 50% of patients we see now that pass to treatment. But we would expect this number to be much improved on the newer version of the technology. For the sake of time, I'll just kind of move quickly through this, but there are some other exciting pending clinical studies testing a variety of uses of BGRT. And with that, I'll just conclude. We've discussed that BGRT is an advanced motion management platform for FDG avid bone and lung tumors. While it is a bit limited now, specifically with regards to indications, improved technology is coming very soon, hopefully. And as that and studies on novel radio tracers begin to pour out, our hope would be that there's a rapid expansion of indications and improved treatment. So with that, I'll cede my time to Dr. Watkins, who has a very interesting discussion for you guys.
Thanks for that amazing talk again. So we're gonna move on to the third part of our session where we discuss treatment planning and evaluation. It gives me incredible pleasure. So we're rounding out our panel with someone who ensures the complex physics behind BGRT actually works seamlessly in practice. Dr. Tyler Watkins is an associate clinical professor and medical physicist at City of Hope. Behind every great BGRT treatment plan is a brilliant physicist, and Dr. Watkins is at the absolute forefront of this space. His latest research leverages artificial intelligence and ImmunoPET to track immune responses to radiation in real time. So while we radiation oncologists figure out where to aim, physicists make sure we hit the moving target with absolute mathematical and biological precision. So please welcome Dr. Watkins. Can take over. Go ahead and share your slides.
I will be discussing nothing about immunopet, but it does bring up a good point that just simply by performing PET continuously throughout treatment and not relying on, for example, old diagnostic images has really changed our practice for lots of patients. So we see new things. And I want this thing off of here. We see new things, right? So we're compared to the 3-month-old diagnostic, we've seen progression, we've seen multi-site progression. And so just bringing PET into the workflow has made a huge difference. And I think this machine can do that on a daily basis or a weekly basis for many patients. So I do have support from reflection. And I'm going to try not to get into too much physics, but the general idea of the machine is if it sees PET, it treats PET. It will perform real-time changes to MU, gantry angle, and MLC shape. But anything within the BTZ, which passes the AC and NTS metrics, will be targeted. So this has led to some mistreatment, unfortunately, and also to some lessons, which I'll talk about in implementation. The dose doesn't change shape. It only changes position. This is a feature, not a bug. That means if your tumor is smaller or, deforming in some way, you still get the same dose shape. And it does consider the entire delivered dose even when adapting or changing treatment. That's the term they call tumor eye view, in which they're accumulating dose to that tumor position. The basic mechanism of delivery passes the couch over the center of the treatment beam 4 times, but it does not change direction mid-pass, so it can't suddenly catch motion out of plane and change direction. And that leads to a necessary opportunistic delivery, where the machine's delivering more MUs in early passes to ensure some strange motion doesn't preclude completion of treatment. And so what I'm showing here is a case we ultimately elected not to treat, in which we saw bright PET signal without CT surrogate. So there's no avoiding this entire bright PET area when we put this patient under BGRT. And this kind of gets back to the idea of 3D PET versus what Syntex is providing us, real-time PET. When we look at a diagnostic PET scan, it's time averaged. That means it doesn't have quantitative value, right? It's blurred due to motion. Even in 4D PET, in which multiple breathing cycles are accumulated based on an external surrogate, you still get this averaging effect due to maybe inconsistent breathing or imperfect match. The time to see something, right, is much greater than the breathing cycle, right? So a 4 or 5 second breathing cycle is a meaningless PET image to what our eyes see. So reflections sort of presents this as real time, and the term they use is not interpretable, meaning they have this noisy image that statistically may identify a region of eye activity that might just look like noise to us. And their current frame rate is about 0.5 seconds. So one thing that's come up multiple times is, how much uncertainty is reduced by this technology. And if the goal is to target and treat the PET active area, then a lot of our traditional uncertainties are gone. So contouring uncertainty doesn't matter. If you put a circle around the PET, whether automatically or manually, if you're targeting that PET region, contouring doesn't matter anymore. Setup uncertainty is gone, so you can have a bad cone beam CT alignment, you're still going to hit the right area. And of course, intrafraction geometric uncertainty is what everybody's been talking about, right? Tracking, change the dose position. But if we're also treating a CT surrogate, then we do require perfect alignment between CT and PET. So any mismatch between the CT done at modeling or done at sim and that PET image will create target miss in that CT region, right? Because the machine will target the PET and doesn't know the geometric area around it, whether it's shifted or not. And for this, I'm working with reflection to ideally perform mid-PET CTs. So the modeling PET might be 20 minutes, and we might acquire multiple CTs during that time to ensure patients aren't moving. When I got the machine and turned it on in the summer of 2023, there were a couple major questions I had to answer as a physicist. And one was, can I treat larger areas? So I have a small PET active volume, but I also have, for example, surrounding bone or CT surrogate. So the PTV size isn't necessarily the target or the PET active target size. So I performed several experiments. I'm going to show you about that. And my next question was, does the dose change if the activity change? So if I have 15 kilobecquerel on day 1 and 10 on day 2, does my dose go down by that factor, or is it consistent? And in the testing, of course, I didn't only use FDG, I used lots of different PET sources, right? So I'm actually validating the machine on all different positron emitters. So I kind of break up Syntix into two sort of modes. If you make a large BTZ, you get real-time adaptation. That's the presentation that Dr. Park and Dr. Schiff made, right? Adapting treatment within this motion. And I validated that mode on pre and mid-treatment shifts as well as breathing motion. But you can also run the machine in more like a tracking mode with a small BTZ, which means any motion outside of this BTZ, I want the machine to interrupt, right? I don't want the machine to try to adapt to something that's far away from my actual target. If the patient had large gross motion, does the system turn off and allow me to re-image and continue? So regarding different PET sources and PTV expansions, I'm showing germanium, sodium, and FDG. I'm showing the sodium source with different size, PTV. All of these results look excellent. And I performed these experiments by copying patient contours onto phantoms, onto PET phantoms, so I could actually deliver the machine and QA the machine in Syntix mode, in treatment mode. This study shows that we can deliver to large PTVs with small PET active volumes. So this is a point source that was concentrically grown in all directions. Once you reach 5 cm sup-inf, the machine has a physical limitation. That's the size of the detector in the current iteration. But I could continue to grow treatment axially and still achieve excellent heterogeneity index, excellent CIs. And so what I'm showing here is you can treat much larger areas than just your PET active volume, and the machine will track on this small region. For real-time autonomous adaptation, I did things like shift a phantom in the middle of treatment. So I would perform maybe 30% into treatment. I would shift the phantom 5 or 10 millimeters and say, does it deliver the correct dose? And so this table here shows what would happen if we did not correct. So what might happen on another machine if your patient moves on the table, and what this machine does. So my conclusion here is taking 20 and 30% error down to the 2 to 5% range is a avoiding catastrophic error, right? So it's avoiding dangerous scenarios that do happen, which we never know about. So I will mention that I also delivered with breathing motions as planned and changed those breathing patterns in all different directions. And in those cases, we do see some interplay effect, whether that's due to latency in tracking or just a general ability to deliver to that high precision. I don't know, but this result led us to only treat patients that move 10 millimeters or less. So others have described the BTZ. I will mention that designing CTV for BGRT, it is advantageous to use a mid-ventilation phase. What that does is allows us symmetric margins about the mid of the ITV, which are naturally treated due to the machine jaw size. With knowing that maybe contouring certainty isn't so important anymore, right? We have our treatment area defined by PET. Knowing that systematic and interfraction motion may be eliminated, we still have some remaining uncertainties, right? We have some PET to treatment center coincidence. We may have some random components of setup error, and delineation uncertainty is going to persist. So performing some margin calculations, Reflection specifically recommends using a biological guidance margin. So an additional margin that we wouldn't typically include in an IGRT plan. That's going to account for tracking uncertainties, for example, due to latency or registration due to CT and PET. Running through some numbers, if we're imaging at 0.5 per second, in mid-ventilation, a tumor might be moving 5 millimeters per second for this kind of simple 10 millimeter motion, 4-second period. So including some random error due to like voxel sampling, et cetera, what I end up with is 8 to 10 millimeters based on using Stroom or Van Herk margin formula. That could be used for BGRT, CTV. If we look at smaller motion tumors and treat the ITV, so we reduce this tracking uncertainty, we no longer need to track in real time. We don't need to account for latency, et cetera. We're just going to treat the motion region more accurately. The ITV margins might only be 5 to 6 millimeters. So relying on the tracking and including the uncertainties may not have as much benefit as we might hope. So here's a simple clinical example. This one's 1.6 supinf motion. With the 10 cc ITV, the tracking PTV might be 32 cc here in red. The ITV-based PTV is 37 cc, and you see we're just sparing a small region, supinf. That said, the patients that are going to benefit the most from this technology will have large motion and large tumors. So when you have this situation, you can talk about 30, 40, 50 cc's of lung being spared by tracking. So I'll show you this controversial slide. The current FDA is for lung and bone. As a physicist and having tested the machine extensively, I have advocated that any PET active tumor should be considered for BGRT on a clinical trial. There's a couple of reasons for this. The primary one being that radiation treatment is not specific to site, it's specific to physics validation. So when I validated that it can deliver in this or that geometry, I validated it for any site which presents that geometry. I'll also mention that all emergent radiation technology is off-label, right? So you get a brand new machine. It's never been tested on patients before, but it delivers the same therapy. It delivers radiation. It delivers the same medicine. So to say it can't be used for something else is a little absurd, but by evaluating different sites, each case kind of teaches us, and we have not treated other sites yet, but we're still considering many patients. Here's a look at an abdominal lymph node, which I think is a really promising treatment for this machine. This is planned on the new X2 system. For patient selection, there's really just two main criteria that can ensure success. One is we need very bright PET, and SUV max doesn't directly translate to what the machine uses, but if you have SUV max greater than 10, it's treatable likely. In the range of 5 to 10, it's going to depend more on size and background. The reason it depends on size critically is volume averaging on PET. So what we're looking at here is a reflection PET of a point source, and it looks like a 2 cm sphere, right? So every PET detector has a point spread function, which creates volume averaging. Also, the BGRT mode uses a 20 millimeter jaw. It does not make sense to treat 10 millimeter PTVs. This will have SUPEMP spill of at least 20 millimeters. I'll just mention optimization briefly for those that are current users. The minimum X1 time I'm able to achieve is about 17 minutes. That's primarily due to long PET imaging mid-treatment. To get down into this time range, I use huge optimization time penalties, identify the treatment minimum, and it does affect plan quality. I'll let treatments go up to about 30 minutes and that's it. In my experimentation with X2, I'm able to treat patients less than 10 minutes. As others mentioned, the plan quality is worse than IGRT or SBRT. Generally, we can meet CI, we cannot meet our 50s, and we cannot carve away from structures near the PET. Also, it does not produce a uniform dose, so it can only kind of dump dose in the center. I will just mention briefly that X2, the emerging technology, has overcome this limitation by abandoning the original PET convolution algorithm for what they call anchor point tracking. And so here's my final slide. Clinically, I'm primarily using Syntax in a tracking mode, not a real-time adaptation mode. And what that means is I use small BTZ. If the patient moves, we interrupt treatment and we resume. And here's a look at cases. This is an MTT, PET, and secondary lung region. This is an L spine in which the patient did move, rotated more than 2 degrees. Machine interrupted, we re-imaged, saw the shift, and continued treatment. So we actually have seen this workflow succeed clinically. So thanks so much. That's it for me.
All right. Wow, that was absolutely a masterclass across the board. Huge thank you to all of the speakers. I have learned a lot already about BGRT. We have realized that while conventional radiation, we require wider margins to account for motion. With the live PET signals continuously directing the beam, and we can do some real-time adaptation and potentially treating even multiple metastatic sites eventually in a single session. So looking forward to more. My brain is completely buzzing with all the high-level science. Please start, putting in your questions in the QA. If you haven't typed in the question, now is the moment. Let's kick off the QA with the first question I had for our team here. First of all, workflow-wise in the clinic, when you see patients, how do you decide who is a suitable candidate? I know Dr. Watkins covered a lot of it in his last few slides, but when do you decide you want to prefer treating or consider BGRT for a patient in terms of, tumor volume or folks for whom this would be the right treatment? And I will let Dr. Amini, Dr. Park, Dr. Schiff kind of take a stab at this one.
Sure, I'll start. So for me, I when I'm prepping a patient, when I'm looking at my clinic, I'm always looking at size and SUV of the patients that are coming to me. What are the I primarily see lung tumors now, and so there's sometimes I'll see lung mets to other places, but especially if it's in the lung or the bone that I know I'm being asked to do a consultation, I'll first look at the most recent PET and see if it's the location of the tumor I'm considering, the size and the SUV, with usually the cutoffs of 1.5 cm of size and 6 of SUV as being the kind of first cutoffs I think about. So if it meets both criteria, then I start thinking more seriously about it. And when I meet the patient, I try to figure out, are they likely to be able to stay on the table and then be able to lie flat a little longer than the conventional patient? Are they likely to be a type who's going to be willing to come in for a little extra, for longer, like each time they're coming for each fraction, they have to be there in the department longer to get the PET scan and also to get the extra PET modeling. So if they're already starting to come in and say, wait, I have to do 5 fractions, that's way too many, then I already get a sense that they may not be, or if they say, I've been waiting for more than 5 minutes, why aren't you seeing me yet, right? That kind of, that kind of patient usually is not going to be interested in doing something like this. So that's usually my first screen.
Yeah, I would agree. I would just add that I typically then message my friendly physicists, which is oftentimes Tyler here. Sometimes we have a couple others, and just have them take a look at the PET scan too, and kind of give me I didn't know, before I kind of talk to the patient.
Yeah, I totally agree with both Dr. Park and Dr. Amini. I think, as we've gotten more practiced with it, we're able to kind of screen a little more effectively, for sure. So it's definitely a bit of experience. And then, as Dr. Park mentioned, but you can actually create synthetic plans ahead of time. So for cases that I feel are borderline, our physicists will very kindly run the plans, and that can give you a bit of a, first look. And, we found we've done a little research on that and found that that's fairly correlative with performance during actual treatment. So it's a very helpful tool.
Yeah, we also we do the same thing for most patients. We also feel like it's not too hard of a sell for most patients to at least try it, because they they always know that there's SBRT backup, and once in a while the BGRT plan is not as good as the SBRT plan, and we'll use that, and I'll tell the patients that, and a lot of times BGRT plan is better, so they appreciate that they have that we have options, and they typically will trust me to just let them know which one I think is better for them after they go through the modeling.
Great. So our next question comes from Alexis Narvaez, who's a rad-onc resident at SUNY Downstate. How do you account for the multiple variables that affect SUV avidity from day to day, such as decay, time to injection, to scan, activity level, noise, etc.?
Experience so far has actually been we've actually been surprised that has not really impacted things very much. Our time of day, we always do the same time of day. We have a block at noon where we do BGRT. So typically that's the lunch hour for our therapists. And if there's a BGRT case, then that won't be the lunch hour. But but at least we always have that spot available when we have BGRT. So that that works out nicely. So at least we don't see variation based on that. One of the concerns I had starting was, are we going to see over the fractions that the SUV is going to decrease over time, and then not be able to pass as time goes along? And we haven't seen that either yet. I'm curious what everyone else has noticed, but that actually has not been a problem for us. Then that's even true when the tumors have shrunk on treatment. They've still been able to pass, and we've looked at all the metrics afterwards, and they're all they're all meeting within the bounds.
I can add that number one, it doesn't matter if it passes the metrics. The absolute value doesn't matter. So that's one of the validation things that I had to find out, right? UT Southwest published a report recently about a patient with partial response. We actually saw a complete response after 2 treatments for one patient. So there have been few reports that early responding tumors are being observed.
Yeah, no, I agree with what they're saying. And, you always have an SBRT plan as a backup. So in the case of that happening, we don't have data to actually adapt off that. There are certainly mechanisms like pulsar that kind of mimic that over time, but not in real-time fractionation like that. So you always just deliver the plan if that happens. Going back to Alexis's initial question, everything's fairly meticulously scheduled, but there are also buffers built within the workflow so that if there are slight aberrations in day-to-day timing, there's basically windows in which certain parts of the steps can occur. It's not like you have to on the dot do each step. That would be impossible in any medical workflow, let alone one as complex as this. So there are kind of windows in which you can do each step to make sure that all of those factors are relatively within control.
The next question we have
I
is,
just wanted to give one more quick point, which is that I also, my experience is just that I tend to treat a lot of primary lung tumors, so we don't typically see that huge response right away. But I think for Mets, you may, if you treat more Mets, you may see that more often, and then you can always choose to stop treatment or to switch to SBRT, like you heard.
Yeah, makes sense. Great point. So the next question we have is, do we typically treat multiple Mets with this technique yet? And if so, like, is there a limit to number of Mets? For example, if there are like 3 to 4 lesions in the same lobe or side of the lung, would you be able to kind of treat them together with this approach?
So far, I can only do one syntax at a time in terms of one isocenter. So that's but you could also the multi-treatment targeting the multi-target treatment MTT. You could treat with SBRT to a second one as well, but in the same plan. But right now, you can't do 2 syntax. But that's the goal ultimately, is to be able to get to that point where you can treat multiple.
I think maybe Dr. Amini remembers, but I think we've attempted 3 multi-syntax, very hard on the patient. Also, you have the decay to deal with. So you have 2-hour decay. So by the time you're at the second site, your the activity is just not the same. But we've attempted several modeling sessions with 2 sites.
And I think we had one patient successfully with 2 sites go through it. That patient had 5 sites, I believe, total, and the other 3 were treated with SBRT. So it was quite a long time treated on a trial that we have.
So Dr. Watkins mentioned something curious that, you don't have to do an appropriate contour. You can just draw a circle and BGRT would ensure the dose reaches the FDG avid region. So what if you were to draw a big circle encompassing 3 Mets? Could it be done in like a single isocenter?
It depends. If they're lumped together and kind of look like one big volume, yes. If they're 3 distinct regions, probably not. But it's an interesting question.
Yeah, great. All right. And then one last question I had was, so briefly mentioned some of the PSMA tracers also coming up, but in the future, and specifically, I have a lot of interest in brain. So are there other radio tracers which Reflexion or other teams are considering, or are they coming up with that to treat tumors elsewhere, specifically brain?
I think, there's definitely at least, theoretical exploration of, several different tracers. I think, I was talking to Dr. Watkins the other day, and he might mention, but theoretically it should be tracer independent as long as you meet certain criteria, and that will only improve with future iteration of the technology. So I think, as he maybe suggested, some of this is just kind of how it's been assessed so far by the FDA, and whether or not that's kind of coherent with kind of how the machine actually works and how radiotherapy is delivered. But there's no reason to think that you couldn't use that for, dotatate, for example, would be one that comes to mind for CNS tumors. So there's no reason to think that wouldn't be possible.
Great. With that, we are officially at the top of the hour. Really massive thank to all our incredible speakers to sharing their expertise, brilliant research, and vision for the future of BGRT. Thanks for all the audience and ACR team. The recording of today's session would be available on YouTube. And we do these webinars quarterly, so you're welcome to come to our next event. Enjoy the rest of your day. Stay curious. We look forward to seeing you at our next event. Bye, everyone.